we're going to talk about flail chest. Now, flail chest is 3 or more adjacent ribs broken in 2 or more places. And what happens here is this causes a loose part of the rib that is free floating and it moves. So it has what we call paradoxical movement. So when you inhale, normally your ribs go out, but here the free floating piece would sink in from the negative pressure being generated. This can be very painful because those broken pieces are rubbing against the rest of the rib, and it can cause pulmonary contusions or a bruising on the lung itself. So here is a drawing of what a flail chest would look like. So you see here we have 3 ribs that are broken in 2 places, and how those pieces are free floating and how they can rub against the rest of the bone. This is usually caused from some type of trauma. So whether it is a motor vehicle accident, a fall, you may see this in blast injuries, compression from a heavy object, or an industrial accident usually causes a flail chest. Now, the alterations to the lung that can occur from flail chest is, of course, rib instability. This also can cause lung restriction. The patient is in pain, they're not going to take deep breaths. Not taking deep breaths is going to create atelectasis, as you see here in the small picture. So the alveoli start to collapse. That can also lead to a secondary pneumonia. And as I said earlier, lung contusions or bruising of the lung itself. On a chest x-ray, this is what you're going to see at the arrows. You will see the broken ribs, so the purple arrows show the medial, and the black arrow over here shows the lateral breaks in the rib. So you have those free floating pieces. Now on the physical exam, you're going to see a decrease in the lung compliance, which is going to cause an increased respiratory rate. You may also see activation of the deflation receptors, the irritant receptors, and the J receptors in the lungs. We talked about those in cardiopulmonary anatomy and physiology. And of course, the biggest thing you're going to see is pain and lots of anxiety. Now, we're also probably going to see cyanosis. And this is going to be from the restrictive part of the disorder and the atelectasis. On chest assessment, you're going to hear diminished breath sounds on both the affected and the unaffected side. Your patient is also going to develop or have very intense pain from you if you push against their chest with your stethoscope. And clinical data is going to show the effects of an increased shunt and decreased oxygen delivery. Since the patient is not taking in deep breaths and we have the atelectasis going on, we're going to end up having a decrease in the oxygen delivery. The other thing that's going to happen, and you may see this in your patient, is what we call pendeluft. In Pendeluft, on the expiration, you'll see that when the patient goes to exhale, not all the air goes back out of the trachea. Some of it will move over to the other lung. Because those ribs are broken, you no longer have an intact system. On inspiration, the patient takes in a breath, part of their chest is going to cave in or suck in. This is going to push air into the unaffected side, and basically it just goes back and forth. This also causes pressures on the heart, which can change cardiac output and diminish venous return. So not a lot of new gas gets into the lung because of the Pendeluft. When this happens, we end up with mixed venous or shunt-like effect blood. So we have a regular ventilated alveolus where unoxygenated blood is coming back. It's being oxygenated like it normally should. But in the area where the flail chest is occurring, you have hypoventilation. So as the blood is coming in, the flail chest is compressing against the alveoli. We're basically not getting the oxygen that we need into the alveolus, especially because of the Pendeluft. So when we mix those two together, our PO2 can be reduced, coming out of the lungs back to the left side of the heart. On the chest X-ray, you may see an increased opacity due to the atelectasis. You should see the rib fractures, and you may see an increased density on the affected side. How do we treat this? Well, in mild cases, we basically give medication for the pain. And we do routine bronchial hygiene therapy to try to make sure that the patient is taking deep breaths, they're able to move secretions. In severe cases, these patients need to be put on mechanical ventilation, probably sedated, and they may need a special type of ventilation called independent lung ventilation. This usually will occur for about 5 to 10 days so that the ribs can heal. We can keep them heavily sedated, pain controlled, and we can minimize the movement of the chest to allow those ribs to start to fuse back together. Of course, we're going to want to give oxygen therapy to any of these patients so that we are minimizing the amount of hypoxemia. And as I said, lung expansion therapy and possibly mechanical ventilation protocols if the patient's case warrants it. This is not something that you see a lot of, but it does require some special types of ventilation and special care when we do see it. So we like to cover it and make sure that you understand this disease disorder.